Hello, and thank you for watching A Better Approach to Parkinson's. I am Robin Fossey, your host and Executive Director of the NeuroChallenge Foundation for Parkinson's. A Better Approach to Parkinson's is an educational program about a variety of topics that are important to the Parkinson's community. Today's program addresses the various eyesight and vision challenges a person with Parkinson's may face. Before I introduce today's guest, I want to tell you about an educational event you won't want to miss. NeuroChallenge Foundation for Parkinson's will hold the inaugural Parkinson's Expo on April 14th at the Robarts Arena in Sarasota. The Parkinson's Expo is a day-long event designed to educate, engage, and empower the Parkinson's community. Like all of NeuroChallenge Foundation's programs and services, the Expo will be presented at no charge to attendees. However, registration is required. While held in Sarasota, the Parkinson's Expo will be a regional event marketed to people with Parkinson's, their caregivers, and medical professionals to over 10 counties in Central and Southwest Florida. The Expo is expected to attract over 1,000 attendees. The Parkinson's Expo will feature presentations from medical experts about topics that are important to you, the Parkinson's community, such as treatment options, the latest in research, managing the non-motor aspects of the disease, product demonstrations, and more. The registration form and list of speakers and topics are available online at neurochallenge.org. We are grateful to Manatee Educational Television for partnering with the NeuroChallenge Foundation for Parkinson's for the Parkinson's Expo and to bring you the A Better Approach to Parkinson's program that presents you with information that will help you live well with Parkinson's disease today. Speaking of today, I would like to introduce today's guest, Dr. Jody Abrams. Dr. Abrams is a board-certified neuro-ophthalmologist at the Sarasota Retina Institute. Dr. Abrams earned his bachelor's and doctorate of medicine degrees from the Louisiana State University. He also performed his internship and residency at LSU. Dr. Abrams was fellowship trained at St. John's Hospital in Warren, Michigan. NeuroChallenge Foundation for Parkinson's is fortunate to have Dr. Abrams as a member of our medical advisory committee. So now I'd like to welcome Dr. Abrams to our show. Thank you so much for being here.
Thank you for having me.
So let's just jump right in. Can you tell us some of the eyesight and vision challenges that are more prevalent for people with Parkinson's?
Sure. While there are many, many challenges involved with this, there are three main ones that we'll see almost on a daily basis with our Parkinson's patients. Double vision is a big cause. Dry eyes and blepharospasms, or squeezing of the eyelids, are very common to come in almost, like I said, daily that we'll see in our clinic.
Let's start with double vision. Can you tell us a little bit about double vision and why it is such an issue for people with Parkinson's disease?
Sure. So double vision encompasses a few different levels. One is where you see two separate images. Like if I'm looking at you and there's a second Robin sitting right here, that would be more of the neurological double vision. And that's more of a misalignment of the eyes. The brain is seeing two separate images and it can't put them together. You also have the double image that people complain about where you're having like a ghosting, where you see an image almost like I'm seeing your head, but it's kind of superimposed. That's more of something doing with the eye. This problem that we have with the double vision in Parkinson's patients is it really messes up their visual spatial relationships. Patients are already having a hard time walking around with the motor function problems with the disease, so now they're trying to look at the environment, see a step over a curb or pick up an object off the table, and they're having trouble seeing where it is. Do I grab this object or do I grab this object? So they're having to close their head, move it around, and it really messes up their ability to interact with the world. So it's important for us to try to control that so that we limit the amount of aggravation that they have with other motor issues.
So when it comes to double vision, is there a certain age or time frame in the diagnosis that you're seeing double vision become an issue, or does it vary?
It can vary throughout the different patients. It depends on how their symptoms, what neurologically is going on. I've seen it in patients very early on their Parkinson's diagnosis. In fact, I actually have a few patients that we've come in to us for double vision, and looking at them, we've actually sent them and have them diagnosed with Parkinson's based on examinations. That's not the more common one. The more common definitely is a little bit later in the disease, but we have had a few early pickups just from the double vision symptoms.
Well, can you talk about the fact that you have suspected Parkinson's in someone from double vision and what that looked like?
They're coming in and they're having the double vision complaints. I can't read clearly. They have something what we call convergence insufficiency, and that's a type of double vision that's very common in Parkinson's and also in head traumas or any other neurologics. And what happens is their eyes, when we look up close, if I'm going to look at this glass of water, my eyes actually have to turn in to look at it to keep both of them focused. In someone with convergence insufficiency, one eye will turn in, but the other eye, instead of coming in, will stay out. So what happens is this eye is focusing on the glass, this eye is focusing over here, so you get a double image. That occurs a lot with reading. Patients will come in and just say, I can't read anymore. I'm seeing blur. I have to cover one eye. And sometimes we'll be looking at them and say they'll either have facial expressions or movement disorders similar to a Parkinson's patient, and that's when we make the diagnosis. Most of the time, though, they are coming to us already with the diagnosis in, and that's when we start looking for the more common causes of double vision, such as the convergence insufficiency.
Well, that's very interesting because I did not realize that your ophthalmologist could actually perhaps be a detector of Parkinson's. So thank you for being that resource for our community. So while we're talking about double vision, how does someone treat that? How do you treat your patients?
Well, the first thing with double vision is, and I tell everybody this, is if you're going to work up double vision, I tell the patient, as soon as you notice it, cover up one eye or cover up the other. Because if you see double vision and it goes away when you cover one eye or the other, that means it's monocular, meaning you see it with one eye. That means we're going to have to treat you for dry eyes or something with your cornea or even cataract type changes. If it actually goes away, every time you cover one eye, you see one glass. Now you see one glass, both eyes you see two. That's going to be something we treat with more of a neurological or prisms. The treatment for convergence insufficiency is actually what we call a pencil push-up. They actually look at a pen or pencil and follow their eyes in, and it's an exercise. And it's like every other exercise. You start going to the gym, your eyes are going to hurt the first few times, but it does help improve. There's some more detailed therapies that we can send them to therapists. We're lucky to have a few of those in town. If that doesn't work, then we can put special lenses in their glasses called Prisms. And what that does is the eye will still stay out or in, but we can bend the light to help get the alignment. If none of those treatments are working, a lot of times then we can go to surgery. It's an outpatient surgery, readjust the muscles and the way the eyes move, and that can help with, to resolve the double vision for these patients.
Very interesting. So is there any way to prevent double vision? If someone has Parkinson's, they're listening at home today, and they're not having these symptoms, is there any way to prevent it?
Not really a way to prevent it. I guess if you wanted to be really proactive, you could start the pencil push-ups, which are take a pen or pencil or even your finger and follow the very tip of it. When it gets to be double or when you see it's very blurred, you can go back out, doing that with your best correction of glasses or reading glasses. Like I said, you do that about 10 times in a row, and that's going to cause a little bit of a headache, which is just like going to the gym for the first time. Do it a couple sets of those a day, and that will help keep that strength and alignment going. The biggest thing is I tell people, use your eyes. Some people think if they're wearing out their eyes, they can't read, they shouldn't watch TV. You're not going to hurt your eyes by using them. It's actually better to keep using them, reading crossword puzzles, reading books, whatever you can do. That keeps the alignment even better.
Well, that's a great tip for all of us to listen to. So tell us a little bit about dry eyes. You mentioned that, and I think that this is something that all of us at some point in time have dealt with. So tell us about dry eyes.
Dry eyes is basically the tear film, something on the front of your eye is losing its ability to help coat the eye. The eye, as we blink, we spread tears across the front of the cornea to make the proper environment. That's how the cornea is getting the oxygen, which the cornea is the very front part of our eye. It also helps get the light in clearly. It's very common in Parkinson's patients to have dry eyes. Multiple reasons for that. Medications, age, lid malpositions, and the biggest thing that we see is Parkinson's patients have this decreased blink rate. If you watch somebody with Parkinson's, they almost have a staring effect, and we call it the Parkinson stare, where their blink rate, instead of every couple seconds they're blinking like a normal person, like you are actually, they'll sit there and maybe in a minute they might blink 5 times. Well, that allows the water to evaporate off their eye, which causes dry eyes, which breaks the light up that's trying to get into the eye to see clearly.
Very interesting. So what are some of the things, how do you treat dry eye?
Well, dry eyes, once again, this is a multiple step thing, and I try to start with the most simple stuff, artificial tears. And you can buy these over the counter. There's multiple brands, Systane, Opti, Refresh, any of these brands. I do tell patients to try to start with one of the name brands. The generics use older preservatives, use older materials to make them, and sometimes that can cause some irritation to the eyes. Then they can't use them as much. So if you're using them once or twice a day, you might get away with generic, but over 3-4 times a day, you want to use it, a name brand. If you're going over 4 or 5 times a day, even 6 or 7, then the non-preserved artificial tears, which are in individual little vials, can be very useful to try. One of the problems we have with our Parkinson's population is getting drops into their eyes because they want to squeeze. It's just a natural reaction that they have, and the caregivers will tell me, or the patient will say, I try to get them in, but I'm having to pry the eye open and it's not fun, so then they don't use it. There is a spray that's available. I think you can buy it on Amazon, or sometimes it's available in the pharmacies. I believe OcuSoft makes it. And the nice thing about the spray is you can hold it just a foot away from their face, spray it, and it'll create a cloud of mist into the air. And they're going to naturally close their eye. It's a natural reflex that we all do. But as long as you don't move your head and you open your eyes within a few seconds, there's enough moisture in there that will help coat the eye and improve the dry eyes. And you do that a few times a day, and that really does help the eyes. If tears don't work, then we can go on to medications. There's Restasis and Xiidra, which are long-term medications you'll put in your eyes. Past that, we actually have some procedures we can do in the clinic. One of those is plugging of the lacrimal tear ducts. Tear ducts are often confused. They think, well, if you're plugging that up, how am I going to make tears? Tear ducts are not for making tears. These are the drains in the corner of your eyes going into your nose. It's the drain of the eye. Takes the tears off. So we put a little temporary collagen plug in there, and what it is, it's like taking a sponge, sticking it down into the drain of your sink, and it slows the tears in the water from leaving your sink or your eye. And that's the idea. And those can be replaced every 5 to 6 months as needed. And that's nice, especially if you're having problems getting the tears in. And last, there's also some surgeries that we can address, moving the eyelids into different positions. Very common, not only just in Parkinson's, but it's also part of the aging process that the eyelids will get loose. They're not holding the tears in position, so when you blink, it doesn't move the water correctly. If the lower lid's hanging down lower, that can allow the tears to run off the eye. So these are procedures that can be done on an outpatient, actually pretty safely with Parkinson's patients, and give good results. Very last would be closing up the eyelid partially on the outside, reducing the evaporative loss.
So let me ask you about the over-the-counter treatments for dry eye. So eye drops. On the directions, it says don't use more than 4 or 5 times per day or consult a physician. So what are the dangers of overusing an over-the-counter eye moisturizer?
If you're using a preserved one, which it's very easy to tell if it's preserved versus non-preserved. Preserved will come in a bottle. It's one that you can just keep in your purse or your pocket and use it throughout the day. Keep putting the cap back on, spinning on. That has a preservative. The FDA requires it in there that says, okay, that way no bacteria can grow in it. And if you use it, touch your eyelid, get it contaminated, it will no longer, the preservatives will kill the bacteria in there. So those you only want to use 4 at the most 5 times a day, because that preservative builds up and actually starts to cause irritation to the surface of the eye and actually can make it feel worse. So then you start to try to use it more, which builds up and causes more pain. If you want to use it over about 4 to 5 times a day, then what you want to do is start using the non-preserved tears, which are in individual little vials. And I tell patients you can break the vial open, pop the cap off, put a drop in. Most of them you can actually push back the cap, use it for the day. If you get rid of it at the end of the day, you're not going to have enough time for bacteria to grow up. And you can use those. I have patients use them even every hour as much as they need to. So you're not going to hurt.
So what do you see in terms, so that's over the counter.
Correct.
With the prescription medications, what are some of maybe the adverse effects or the downside to the prescription medications?
The two main prescriptions that we use long-term are Restasis, which has been the gold standard for a long time, and Xiidra, which is the newer kid on the block. The big adverse effects, the big thing that we have is a lot of patients don't tolerate it because it can burn and cause irritation. So that's our number one cause of failure for those. The second thing is that it takes about 6 to 8 weeks to really start working. They're not a drop that you can just put in and all of a sudden you get relief. These are things that are long-term effects. So patients sometimes don't want to wait that long. They don't like it. And the other thing is they can be very expensive depending on your pharmacy plan. But for the most time, there's really low long-term risk effects with the Restasis or Xiidra. Sometimes at the beginning, we'll use a short-term medication, a steroid drop to kind of, if there's a lot of irritation, if they're having a lot of pain to their eyes, we'll have them put it in for a month or so. That you don't want to do long-term because steroids can cause glaucoma, cataracts, thinning of the eye. But in a short period of time, like a month or so, most patients tolerate that very well.
And when you talked about surgery as an option, and so in general, how many or what percentage of patients that you see who perhaps have Parkinson's with dry eyes would end up having surgery?
Probably less than 20% really we get to that part. It's not the more common one with the Parkinson's population. Usually we can control them with the artificial tears. Often the plugs are used and those work well. So a combination of those two control most of our patients. The ones that we're having to do surgery are the ones that have just severe dryness. Maybe they've had previous eyelid surgery where they've had their upper eyelids lifted and now they have a little bit more exposure, or they have an underlying other rheumatologic or other disorder that's causing their eyes not to produce very good tears. Those are the ones that we usually have to do it. Or if they just have extensive lid trauma from maybe extensive sunburns or other procedures they've had done in the past, sometimes we have to adjust lids for that.
Are you aware of the medications for dry eye to interact with any of the Parkinson's medications that are
No, we really
popularly
haven't.
used?
I mean, the ones that we use are pretty innocuous. And the nice thing about the eye is it's somewhat isolated from the rest of the body. The drops that we put in, while they're a high dose on the eye, once they get into the tear duct system and into the regular systemic part of the body, they really don't have too much effects for there. So we don't see any interaction really with the Parkinson's medications and any of the dry eye medications that we use.
And when you talked about the tear duct plug, how often then would a patient that has that procedure done, how often would they have to have it redone?
Usually the ones that a lot of us are using now are collagen, which they temporary and they dissolve. And most of the time it's about 5 to 6 months. So about twice a year we'll have the patient come in. It just takes a few minutes in the clinic to do it. We put a little numbing drop in there and it's just a pair of forceps that we use to insert it. And people tell me even without the numbing it feels like changing your earring. So once it's in, you don't see it or feel it. There are some permanent ones that are available, but most of us have kind of stopped using them because they can break off, they can get infected, and you change out to a fresh new one with the collagens a little bit easier. If the patient's having to come in often and they just maybe, we know, hey, their disease is progressing and we don't want to have them keep coming into the clinic every 5 to 6 months. It's hard on the caregiver or the patient. There are procedures we can do to permanently close them with a little cauterization, and that can work very well too.
Okay. So do you think that a person with Parkinson's disease is more likely to develop dry eyes than someone in the average population?
Yes, definitely. Mainly because of the medications that they're on to treat the Parkinson's can dry out their eyes, and also because of the decreased blink rates that they have.
So is there anything preventative that can be done for a person who's watching the show today who has Parkinson's disease, but perhaps is not affected by dry eyes just yet? Is there anything they can do?
Not really anything you can do. I mean, one of my partners will tell people drink a lot more water and to blink more, but that's hard to think about all day long. And the problems with drinking more water can be there too. So, I tell people get used to maybe having the artificial tears, get used to putting it in your eyes would be a good idea. If you never wore contacts, it's funny when we go to put drops in people's eyes, no Parkinson's or not, you can tell people who have had contacts and are used to having their eyes messed with others who have never done that. So if you think you might want to do something, try putting artificial tears in twice a day. It's good for the health of your eyes. It'll wash out any debris or irritants, and it'll just get used to using them and making it part of your normal routine.
So I have allergies, and so I know antihistamines, I've heard, can dry out the eyes. Does that happen?
Yes,
Okay.
allergies, medications are very common to dry out the eyes, and we get a lot of patients when the allergy season's coming up, they not only have irritation of their eyes from the allergies, but also increasing dryness.
Very interesting, and that's great information for people in general who may not have Parkinson's, so for our caregivers who are listening. So let's talk about the blepharospasms, which is a new word for me to say today. So tell us, what are blepharospasms?
Blepharospasms are a spasm of the muscle around the eye. And in the eye, we have a muscle that goes around here called the orbicularis. And that's what closes our eyes. So when we squeeze, the muscle that lifts up the eye is called levator. It relaxes, and this orbicularis will close, and that's what allows us to blink. In blepharospasms, you get an overaction of that muscle. So now the eye, instead of just quickly blinking, it does this. And it's almost like they're really in pain, squeezing their eyes. And a lot of times they're doing that, they're trying to open and they can't see because of it. And you can get these spasms that are setting up for that. So that's a blepharospasm, and it does become more common in Parkinson's patients.
So, well, that was going to be my next question. So what exactly does that look like for a person with Parkinson's on a regular basis?
It's like they're blinking and squeezing like something's in their eye. They're doing this the whole time, where they're just kind of squeezing their eyes tightly shut. It's not just a blink and they close their eyes and there's no muscle contraction. That can be other issues going on. But a blepharospasm's more of a just forced closure almost going on with their eyes. And you tell them, hey, watch TV, and you look over at the Parkinson's patient and they're doing this, that's the spasm issue that we're worried about.
So you said that it is more common for people with Parkinson's disease. Yes. So is it also more common with other neurological disorders?
Yes, any of the neurological disorders can occur. And it can also be one side or the other, and you can have it with no neurological disorders.
Okay, interesting. So is it more common to be unilateral or for both one eye, both eyes?
In Parkinson's, it's usually, we see a lot more of it bilateral with both eyes. In the general population of patients with blepharospasms who are not related to another underlying neurological disease, it a lot of times will start off unilateral, and some of those will progress to bilateral.
So what are some of the treatments?
So the treatment for this is actually kind of fun and neat for us because it's a history of a drug that we all know, Botox. Botox, as you all know, is out there for cosmetics. I mean, you listen to it, everybody in Hollywood. But what's interesting is you look back in the history, back in the late 70s, early 80s, Dr. Alan Scott out of California was treating patients for spasms. And back then we used to do these horrible surgeries where we would take all the muscles out, and it was very disfiguring and it never worked. Or you'd give them medications that were sedating. And he started saying, what if we just temporarily paralyze the muscle? So he invented Botox, and it was originally approved by the FDA for two things, the blepharospasms and actually strabismus or double vision, a misalignment of the eyes, especially for kids. And we still use it for that some today. Then, of course, in the 90s, it became popular for cosmetics, and now it's used for everything under the sun, including migraines. But it does work very well, and it's still the standard treatment that we do for blepharospasms. It relaxes the muscle enough that the spasms are weakened so they don't have that closure of the eyes. It's about 5 or 6 injections on each side. It takes just a few minutes to do in the clinic, and it lasts for about 3 to 4 months on average. You do have to be careful with it, because if you give too much, then they don't close their eyes very well. Well, you take a population who's already tending to have some dry eyes, so you got to be very careful. So it is a balancing act of sometimes you start lower, build up the dose, and then have to adjust it as you go back and forth.
So what may be some of the adverse effects to having Botox treat the blepharospasms?
The big thing is the dryness, the what we call decreasing their blinking ability, so they can't close their eyes as well. You can actually also cause some double vision depending where the Botox goes. You can actually drop the eyebrows even further down, or the eyelid can close to where they can't open. So you got to be really careful at where you're putting it and in the positions that it would go.
So is there any way to prevent having blepharospasms?
Yeah, I mean, if you start to see somebody with it, one of the earlier treatments we always tend to try is to do artificial tears, because sometimes just dryness and irritation can cause it. So we try to say, once again, treating the dryness very early can be very useful. Past that, there's no other really treatment that we can use for it. If it progresses and the Botox doesn't work, there are some other medications that we sometimes use, but they're not well done in Parkinson's because they can be very sedating. So we try to avoid those.
So, Dr. Abrams, you have presented for Neuro Challenge at our distinguished speaker event before, and your information, people really had actionable take-home things that they could do to help manage whatever their situation, dry eye, double vision, that they could manage today, and also to be able to seek the appropriate medical help. So what would you say, when is it time to go and see a professional about vision challenges?
Vision, I mean, as soon as you start to notice that you're having difficulty reading or seeing the TV or trying to drive, you don't wait on it, don't get frustrated. One of the things I hear often from caregivers is, you know, my spouse used to love to read, but then they stopped it, and I asked the patient why, and they said, it wasn't for me, I wasn't getting, you know, I wasn't seeing well. And they've been going for this for years, and they never told their doctor, never went to see an eye care professional. So don't think you have to give up all this stuff, you know, because you have Parkinson's or any other disease going on. Go see as soon as you start to notice it, go see your eye care professional. Let them know that you are diagnosed with Parkinson's. Let them know what's going on. When you call to make your initial appointment, tell them, I have Parkinson's, so that way they can maybe block out a little extra time. It's not the normal 65-year-old patient who's coming in with a cataract evaluation who has no other problems. They need to take a little bit more time. They need to investigate motility of the eyes, which is not done on a normal basis. They need to look for those things.
So you are a neuro-ophthalmologist, and my understanding, so you may have to correct me, but I believe there's only about 400 of you in the country. Is that correct?
Yeah, we think there's about 400 to 500 of us. Some people are trained in it, but they don't always practice it. A lot more of us are in academics or in research. So we say about 400 of us around the country.
So would you recommend that a person with Parkinson's seek a neuro-ophthalmologist, or can they start at an ophthalmologist?
I would say you can start with any of your eye care professionals, because most of the time they can treat the more simple dry eyes and some of the other stuff. I think if you're not getting to where you want to go, or if they're having trouble and you're still having double vision, then it's important to come see the neuro-ophthalmologist. I'd love to see all of them, but unfortunately with so few of us around the area, there's only so many patients we can see in a day. But we try to educate all of our other eye care professionals. I give lectures quite often through the year to them about the challenges with Parkinson's patients, and they know that when they see them, there's going to be some other things to look for.
Well, in closing, what would be your take-home advice for our listeners and our viewers today in terms of managing their eyesight and living well with Parkinson's?
The big thing is get your eyes checked. You should be getting them checked yearly. Tell your healthcare professional, your eye care professional, any problems you have. Don't just downplay it. Oh, my eyes feel irritated. I'm seeing a little blur when I read. Tell them there's a lot of things that can be done. So, you know, if you don't tell us, we don't always know. If you just read the eye chart and you're seeing 20/20, we're going to think everything's fine. You have to tell us the symptoms and problems you're having. So speak up when you're in there. Let your caregivers also stand up and say what's going on. That's the big things. And then we can address it. A lot of things are what we have to do in the clinic for the patient.
Dr. Abrams, I thank you so much for taking the time to be with us today. And also I thank you for what you do for the Parkinson's community each and every day with your patients and with many of the people that we serve. So thank you very much.
It's a pleasure. Thank you.
And thank you for joining us today. I hope the information discussed here was helpful in navigating your journey with Parkinson's disease. We hope you will become more engaged with Neuro Challenge through one of our monthly education or support programs. Education and information are essential to successfully navigate the challenges of Parkinson's. All of our programs are available on our website at neurochallenge.org or call us at 941-926-6413. And before you go, don't forget to register for the Parkinson's Expo online. Online registration is strongly encouraged due to very high call volume. Thank you again for joining us for A Better Approach to Parkinson's. I look forward to seeing you here next time.